In Japan, Japanese cedar pollinosis is a big national problem. The prevalence rate in 1998 was 16.2%, in 2008 was 26.5%, and in 2019 was 38.8% of the national population, increasing about 10% each 10 years. On the other hand, perennial allergic rhinitis only increased slightly from 23.4% to 24.5% in the same 10-year period. This increase of Japanese cedar pollinosis in Japan is mainly due to the increase among young people. Especially noticeable is the increase in 5 to 9-year-olds from 7.5% in 1998, 13.7% in 2008, to 30.1% in 2019. Also, in over 70-year-olds, the rate increased from 5.6% in 1998, 11.3% in 2008, to 20.5% in 2019. This slide shows the strategy for the treatment of pollinosis according to the Japanese guidelines for allergic rhinitis 2020. Immunotherapy is the baseline therapy for reducing reactivity against the antigen. Adding on anti-IgE therapy to the baseline therapy is permitted for severe pollinosis. The history of subcutaneous immunotherapy, or SCIT, was started in 1911 by Dr. Noon, and sublingual immunotherapy, or SLIT, was started in 1986 by Professor Gressis Scotting in England. And now SLIT is the main immunotherapy used in Japan and internationally. TO-206, Japanese cedar tablet for SLIT, was developed in Japan and tested with clinical trials published in the Journal of Allergy and Clinical Immunology in Practice and Allergology International. We conducted a double-blind, randomized, placebo-controlled trial with 1,042 patients in 4 arms in the dose-finding period. We then continued from the placebo and 5,000 Japanese allergology unit groups after re-randomizing the subjects into a placebo group and a 5,000 JAU of Japanese cedar allergen group. The result of the dose-finding trial is shown in this slide through the pollen season. The gray line, this one, is the placebo, and the purple line down here is 5,000 JAU. The total nasal symptom and medication score appears to be the lowest with a dose of 5,000 JAU or more. This slide confirms what the previous graph suggested. The total nasal symptom and medication score in the peak symptom period was significantly lower with 5,000 JAU and 10,000 JAU than with the placebo or 2,000 JAU. There was no significant difference between 5,000 JAU and 10,000 JAU. Individual symptom scores, which include sneezing, rhinorrhea, nasal congestion, itchy eye, watery eye, were significantly lower than the placebo in each of the active groups, and the use of rescue medications, such as eye drops or antihistamines, were also significantly lower in the active groups than the placebo group. This slide compares least square means of the total nasal symptom and medication score during the peak symptom period of the dose-finding period between children aged 5 to 17 years and adults aged 18 to 64 years. Both age groups have no significant difference in efficacy. The adverse events in the 3 active groups were similar. The main adverse events in this trial were mouth edema and irritation. Mild local reactions at the administration site were reported as the most frequent treatment-related adverse events. No serious adverse event occurred in this trial. The incidence of treatment-related adverse events was about 60% in the young age group and about 50% in the adult age group. This was not significantly different. This slide shows the total nasal symptom and medication score in the 3rd pollen season during the trial. PP means placebo in both stages of the trial. AP means 5,000 JAU only in the first year and then placebo for the following 2 years. PA means placebo only in the first year, and then 5,000 JAU in the following 2 years. And AA means 5,000 JAU for all 3 years of the trial. In the third season, compared to the placebo, the total nasal symptom and medication score was reduced by 35.3% in the AP group, by 41.0% in the PA group, and by 45.9% in the AA group. This study was continued for 2 more years without SLIT treatment. The group that received 5,000 JAU consistently for 3 years still demonstrated a 45.1% reduction in symptoms 1 year after treatment was stopped, and then 34% 2 years later. The PA and AP group also showed significantly reduced symptoms in 2 follow-up seasons after the treatment period ended. This study demonstrated the sustained clinical efficacy of Japanese cedar pollen SLIT tablets during 3 years of treatment and a disease-modifying effect for at least 2 years after the completion of the treatment. From the AP group, which is the group that had the treatment first and the placebo second, we found that 15 months of treatment with Japanese cedar pollen SLIT tablets could suppress the symptoms for 3 seasons after completion of the treatment, however, not during the 4th season. These results strongly suggest that efficacy for longer periods could be obtained by treating patients with Japanese cedar pollen SLIT tablets for 3 years. Next, we performed the double allergen SLIT study for Japanese cedar pollen and house dust mite allergies. This combination was chosen because the number of patients with a combination of Japanese cedar pollinosis and perennial house dust mite allergic rhinitis is increasing now in Japan. Subjects were randomly divided into 2 groups. One group received the Japanese cedar pollen treatment first, and the other group received the house dust mite treatment first. The mono SLIT treatment period was 4 weeks, and then dual SLIT was conducted for 8 weeks in order to evaluate the safety profile of double SLIT. This slide shows the dosing schedule. During the dual administration period, the allergen that was given during the mono period was sublingually administered and swallowed after 1 minute, and then the second allergen was administered within 5 minutes after swallowing the first one. The treatment-related adverse events by period are shown in this slide. In the Japanese cedar pollen first group, the incidence of adverse events was a little higher in the dual administration period. On the other hand, in the dust mite first group, the incidence of adverse events was a little higher in the mono SLIT period. So it appeared that house dust mite allergens caused more treatment-related adverse events than Japanese cedar pollen. This could be due to the greater dosage of the house dust mite tablets. The Japanese cedar pollen product was 5,000 JAU, while the house dust mite product was 10,000 JAU. The main adverse events were mouth swelling, oral pruritus, throat irritation, and discomfort. We also looked at the change from baseline levels of specific IgE and IgG4 for house dust mites and Japanese cedar pollen in the house dust mite first group and Japanese cedar pollen first group. Both groups showed elevated IgE and IgG4 levels for Japanese cedar pollen and house dust mite appropriate to the period when the allergens were administered. The clinical question of double SLIT was, first of all, which treatment to start first. We think that treatment should begin with a causative antigen that has the highest clinical priority or that has the strongest clinical symptoms. And cedar pollen SLIT, of course, cannot be started during the cedar pollen season. So what about when to start the second treatment? If no side effects are observed with monotherapy and the condition is stabilized, then the second treatment can start. During the dual treatment, the 2 tablets should not be taken at the same time. The timing between the tablets depends on the patient's lifestyle and the side effects that have been observed up to that point. As I already mentioned, the clinical symptoms of Japanese cedar pollinosis include sneezing, rhinorrhea, and nasal congestion, which affects patients' daily life, such as their study or work, sleep, and outdoor activities, and which result in impaired quality of life. Usually, patients with severe Japanese cedar pollinosis are treated with a combination of nasal corticosteroid and antihistamine, or with nasal corticosteroid, antihistamine, and leukotriene receptor antagonist in non-specialist outpatient clinics. However, these standard therapies are often not effective, which highlights the significant unmet need for the treatment of Japanese cedar pollinosis. Omalizumab is an anti-IgE antibody that blocks the binding of IgE to high-affinity receptors, thereby preventing IgE-mediated cellular responses. In the study that I will explain next, we evaluated the efficacy of omalizumab added to the standard treatment of antihistamine and nasal corticosteroid in severe Japanese cedar pollinosis patients. IgE binds to mast cells or basophilic cells through the interaction between C epsilon 3 and Fc epsilon R1. Omalizumab blocks this interaction by binding to C epsilon 3 of specific and non-specific IgE. We performed a multi-center randomized, double-blind, placebo-controlled study. The subjects were patients who were unable to adequately control their severe Japanese cedar pollinosis with the current recommended therapies. The concomitant treatment was fexofenadine taken continuously throughout the season and topical fluticasone at the peak of the season. Dose and dosing frequency of omalizumab was determined by the dosing table based on body weight and serum total IgE level. Omalizumab or a placebo was administered subcutaneously for 12 weeks. The primary endpoint was the sum of the scores for severity of sneezing, rhinorrhea, and nasal congestion from 0 to 12 points. Secondary endpoints were individual symptoms and other questions on a questionnaire. We also gave a WPAI-IA questionnaire, which stands for Quality of Life and Work Productivity and Activity Impairment, allergy specific. This slide shows the changes in the nasal and ocular symptom score through the pollen season. You can see the effect of omalizumab, which is the red line, compared to the placebo, which is the gray line. During the period when the nasal topical steroid was given, the difference in nasal scores between each group decreased. On the other hand, the difference between the ocular symptoms of both groups remained the same. Omalizumab significantly reduced the nasal symptom score during the severe symptom period versus the placebo. Each of the three symptoms, sneezing, rhinorrhea, and nasal congestion, during the severe symptom period were consistently lower with omalizumab than with the placebo. These are the results of the subgroups analysis. In all the subgroups of age, gender, coexistence of perennial allergic rhinitis, severity of nasal symptom in previous season, and baseline total IgE, omalizumab had a significantly superior effect for Japanese cedar pollinosis symptoms. Omalizumab also reduced the ocular symptom score during the severe symptom period versus the placebo. The symptoms itchy eye and watery eye during the severe symptom period were consistently lower with omalizumab than with the placebo. The RQ-LQ score, standardized to the Japanese population, was also evaluated in this study. In each category, daily activities, outdoor activities, social life, sleep problems, physical problems, and emotional function, omalizumab significantly reduced the quality of life problems. Work productivity loss, according to the WPAI-AS survey, was improved with omalizumab as compared with the placebo. The most frequently reported adverse events were nasopharyngitis, pharyngitis, and flu in both treatment groups. The only severe adverse event was a testicular neoplasm in one subject in the omalizumab arm, which led to discontinuation of the study drug. This was resolved with surgery and was not considered to be related to the study drug by the investigator. There were 2 cases of adverse events leading to discontinuation of the treatment. There was no significant difference in adverse events between the 2 groups. In patients with severe Japanese cedar pollinosis, adding omalizumab to the standard treatment consistently improved the nasal symptom score, ocular symptom score, quality of life, and work productivity. Omalizumab was well tolerated. No new or unexpected safety concerns were detected. Findings from this study indicate that omalizumab therapy has the potential to optimize the overall management of patients with severe Japanese cedar pollinosis. Currently, in 2022, we are making the 9th version of the practical guidelines for the management of allergic rhinitis in Japan. The strategy for management of allergic rhinitis, especially of Japanese cedar pollinosis, are improving and continuously being updated in Japan. Thank you for listening.